pages in this chart, so I know you guys said you wanted a bigger one. So hopefully we can get through this in 20 minutes. So this is a real medical record. This is de-identified, so there's not any information that will tie us to this patient. I just wanted to point that out. That's why you'll see some, missing information where you can tell that we've highlighted it and removed information. Too small. Okay, let me see how I can make this bigger. How's that? Is that better? Okay, perfect. Okay, so our patient is a 33-year-old. So as I'm coding, I always pay attention to the age, okay? Because like I told you guys before, age does matter in pregnancy, right? We need one of those bumper stickers. Age does matter. So 33 is normal. There's nothing to worry about age there. So we can move on. So 33-year-old, gravida 5, para 4, 004, so that means she's been pregnant 5 times, has had 4 births, and at 4 weeks postpartum. Patient went to local ER for wound infection and was treated with antibiotics for 1 week. She cannot remember the name of the medication, has 2 doses left. Since then, her incision has become more red and tender and is opening up in areas. So, she obviously had a C-section right as she had an incision, so let's look. Delivery type C-section without labor. She didn't have any lacerations. And then it says postpartum complications. She had a wound infection. The newborn's alive and well. She's breastfeeding. She's been bleeding for 3 weeks. She's not on any current contraception. She does want some later. Her look at that, postnatal depression is a score 2. And then the medical history is negative for all of this. Labs, nothing there to look at. Okay, let's look at the physical exam. I won't go through all of this, but if we go down to the abdomen, it says her incision has erythema, swelling, odor, and some areas that are open. Okay, the pelvic looks good. So the assessment is a routine postpartum follow-up, so obviously she's coming in. And history of a C-section, and then a wound infection after surgery, initial encounter by Dr. Joe, let's say, into look at infection, spoke with Dr. Joe, and patient will be directly admitted to 95 for wound debridement. So let's go to the next report. Okay, so here she has had a length of stay of 1 day, so we know she's at a hospital, right? She's been there overnight. She was admitted for a wound infection. She had another fever at 20:04, so this is military time, of 39.3, but has come down with Tylenol and Motrin. She felt ill when she had the fever with headache, but now feels much better. No shortness of breath, chest pain, or headache. So those are the meds. We won't look at those. Those are her vitals. We won't spend time at those. Okay, let's go look at the incision again. So her C-section incision is mostly intact. Left aspect open about 2 centimeters wide by 0.5 centimeters deep. Packed superficially with idioform gauze. Right side open about 0.5 centimeters and 0.5 centimeters deep. Packed with idioform. Packed areas are covered with bandage for drainage. No evidence of cellulitis or further induration. Okay, so we're going to just skim over the labs again. The assessment and plan. So the wound was open and packed yesterday. So that had to be on hospital day 1, right? Since this is overnight. So we know on hospital day 1, they opened the wound and packed it. They're continuing with her antibiotics. I saw and evaluated the patient. I discussed the patient with the resident and agree with the findings as planned and documented in the resident's notes, which was the wound packed, the cellulitis is improving, fever is a little concerning, working diagnosis remains as the wound infection. Okay. And this was 5/28. one. Now you guys will see she's been here 3 days, right? Her admit date was 5/27. We just read the 5/28 report. Here's another one. Overnight, she was admitted for a presumed wound infection. The last fever was 5/27. She feels great. Still the same antibiotics. The vitals are there. The incision is mostly intact. Left aspect open about 2 centimeters wide by 0.5 centimeters deep. Packed superficially with the gauze. The right side open, 0.5 centimeters and 0.5 centimeters deep. No evidence of cellulitis or further induration. There is a large amount of nystatin powder surrounding the incision. There was drainage that appeared somewhat purulent at the incision site. So, for labs, again, we're just going to scan over those. So, the plan was wound opened impact 5/27. The fascia was intact. Continue the antibiotics. Consider adding something if she remains with a fever. Her white cells are good. Wound and blood cultures are pending. They're giving her Tylenol. Continue the powder. Change the dressing in the morning. And then we'll plan to return to see the incision. Okay, so 5:30, so 3 days after admission, I saw and evaluated the patient. I discussed the patient with the resident and agreed with the findings on the resident's note. Compliment a little low, but patient does not meet the criteria for SLE despite antibody level. Looks like wound infection, need to open further and continue to pack. So let's see if they open it again. Patient's wound was examined. There's no erythema around the incision site, no purulent drainage or tenderness. She's afebrile. After discussing it with Dr. Joe, the purulent appearing drainage was likely the nystatin powder mixed with the serous angiitis drainage. The incision does not look infected. Will not open incision further as it could increase the risk of complication and infection. Okay, so that's very important. I wanted to point that out. So just because up here he says, looks like we need to open, okay, down here they're saying, no, I don't think we're going to open it. Okay, so here's our medication list. Okay, so here's our history and physical. Remember, these are always done on admission, so if we look, this was done at 5/27, which was her day of admission. So again, a 33-year-old, now it's gravida 5, para 5, post-op day number 32, which is the post-op delivery for her. She had a repeat low transverse cervical C-section, is that abbreviation, 425, who presents from clinic for direct admission due to wound infection. She first noticed that the area on her wound was damp, but thinks it was sweat at the time. She did not notice an odor and did not have fever. She began to have an odor to her wound and increased erythema and pain at her site. She presented to the hospital ED about a week ago, was treated with antibiotics for 1 week. She has not noticed any change in the wound, and she felt like she had a fever this morning. Although I did not take her temperature, she went to post-op visit today, where she was examined, and due to the concern that her wound may need to be explored and debrided, she was directly admitted to the hospital and had a fever. Okay, so that kind of paints the picture of what's going on with her, right? So we won't look at all, her personal status. Okay, so here's the admit note. They're going to admit her, do her labs, look at her cultures, put her on antibiotics. Okay, discharge summary. Remember, this is always the story of what happened. Now, typically, most hospitals put the discharge summary first. So I apologize for not reading this first, because this should have been our first point of reference here. Or I prefer to read them first. Because again, it tells you the whole picture. So, our patient is a 33-year-old who presented on the clinic post-op day 32, status post uncomplicated repeat cesarean delivery with a fever and concern for wound infection. The wound was examined and had 2 small areas that were opened but did not appear infected. There was a small amount of erythema on the superior aspect of the incision line. An ultrasound was performed at bedside and there was no underlying abscess. Urine and blood cultures were negative. She was treated with gentamicin and clindamycin. She complained of joint pain on presentation, so an ANA was ordered and was positive. On hospital day 2, she remained febrile and her wound continued to appear without infection. She did have a few temperatures that were not a fever, but at the higher limit of normal. On day 3, a chest x-ray was performed and was normal. Her C3 was attained and slightly low. C4 was normal. There was concern for possible purulent discharge from the incision, but she had been afebrile, and when the incision was re-examined, there was no drainage, erythema, or fluctuance. Decision was made to not open the incision further. She felt well and desired discharge home. Her pain was controlled. She was ambulating, tolerating a regular diet. She was discharged home in good condition. So, discharge instructions. You don't have to read through all of those. Discharge meds. So here's the med sheet. Again, discharge instructions for patients who have had a C-section. Okay, so that's end of our record. So if we come back up here to our discharge summary, okay, so what do you guys think we're coding here? She had infection to her C-section wound, right? That was documented over and over and over. So let's go to our index, your PCS or your CM book, sorry, and we're going to code the delivery complicated by the OB infection of her C-section wound. So I'm going to give you guys a minute and see what code you come up with. And I'll give you guys a hint. This one is easiest to find under the main term complication and then obstetric. what code did you guys find? Hopefully you went to complication, obstetric, and then surgical wound, right, infection. So our code is 086.0. Is that what everyone has? That's our principal diagnosis, 086.0. Now, because she already delivered, we don't have an outcome of delivery Z code, right? So we're not going to code an outcome of delivery because that occurred on a previous admission. She did not deliver anything this time. A baby did not come out. Baby's already out, so we're not coding that. So the next diagnosis code that we want, we looked right here. They talked about her ANA being elevated, and they're going to follow her with outpatient visits regarding that. So we want to code that. So we're going to code elevated. ANA is the antibody titer. So in your index, if you go to elevated and then antibody, and it's on page 128, R76.0. Hopefully you guys see that code. Some people would code the former smoking, here the history of nicotine use, which most hospitals have a policy about that. Since she isn't currently smoking, she quit, looks like years before the pregnancy. There's not a coding guideline to tell us really one way or the other. So to code that, you would look under the personal history. We're almost out of time, which is D87.891. And then we also want to code the procedure, right, because they did the packing of that abdominal wound. I'm kind of disappointed that we don't actually have, like, the note for that. We just know that it was done. I don't know if part of this chart is missing. We know that they weren't going to open it a second time, as they discussed right here. But they did open it and pack it at one time. Yeah, wound packed, opened, and packed yesterday. So this is hospital day 2. So on day 1, it was open and packed. So we're going to code an ICD-10-PCS for that, because remember, anytime you're coding an inpatient chart, our inpatients are coded with ICD-10-PCS. Outpatients are coded with CPT procedures. So remember, for those of you who have had 203, the trick to PCS is by always looking up the root operation. So packing is what they did. That's our root operation, right? That's the intent of the procedure. So for those of you who have an ICD-10-PCS code book, if you want to open it and go to packing, and then they did her abdominal wall, right? So in our book, PCS book under packing, abdominal wall, we get all 7 characters, which is great. 2W43X5Z. is our PCS code. So for this case, we have the 086.0 for the infection of her obstetrical surgical wound, the R76.0 for her raised antibody titer, the D87.891 for the personal history of the nicotine, and then our procedure code is 2W43X5B for the packing of her abdominal wall. Okay, I'm going to go back, see if you guys have any questions before we end, because we're right at an hour. I'm sorry, I know I always go over. So I just wanted to end with, don't lose hope. If you don't get coding today, you'll get it tomorrow. It's all about practice.